Hi, it's me, Brody McLeod, coming to you from my laptop camera today just to make a bit of a change. I woke up and hospital Wi-Fi appears to have gone down. Just doing a research paper, or I've been kicked off the network rather. My laptop still has a Wi-Fi connection, but my phone doesn't. No one cares about that. Today I want to make a video about the NHS, right? Which is something which is so powerful in the sort of nationalistic consciousness, and probably one of the things that people are most proud about in Britain. The fact that we've got free access to healthcare is fucking amazing. Like, so many countries don't have that. We've got a welfare state, and we've also got a free education system. Those three things are so vitally imperative to the structural integrity of our nation and have a huge value, intrinsically impossible really to quantify, over and above these statistical and financial figures. The social value and the personal value is enormous. My mum was actually an NHS nursing student in her third year on placement on Turner Ward, which is a hospital in Torquay in South Devon. It's a cancer ward. She sadly, on St George's Day in 2014, was struck down with cancer. So they were just doing my obs there. My mum passed away from cancer and ended up on the same ward that she'd been treated on. And the way that she was so keen and eager to finish her nursing degree, and how much she was enjoying her placement, being able to help people who were, some of whom, on the road to recovery, thanks to things like chemotherapy, radiotherapy, all the amazing free treatments that cancer patients receive from the NHS. The way that my mother, Alethea MacLeod, was treated was kind of suboptimal. They told us, I actually looked through her medical file in the little trolley outside the room. I shouldn't have done, but I saw her name on it, and I went to visit her at one point when she was in this, right at the end of Turner Ward, this kind of like a little isolated room, and she was in this kind of boxed off room on her own rather than on the open ward at that point. And I looked in the notes, and I've been in and out of mental hospital. The first time I was sectioned was in 2012, but I'd been out of hospital for 2 years. I'd gone back to work as a business development exec for a booze firm and as a chef, and was on the road to recovery myself, with, let's not forget, the help of an NHS community mental health team and a brilliant lady who helped to nurse me back to good health from the specialist team for early psychosis at Torbay in South Devon NHS Foundation Trust, I believe, or maybe Devon Partnership Trust. I think it was DPT. And there's just such a sort of a caveat or a chasm between sort of like the way that my mum portrayed to me as her son the ward that she was working on, Turner Ward, and the sort of the level of care that was there, and the miraculous recoveries that people were making, and the level of facilities and the hard-working nature of the staff. She said, the people who work there are just so clued up. They're so astute and professional, and I'm really enjoying my placement. She didn't smoke or drink for like 10 years before she fell ill. And it was so quick. She was admitted to the ward and died about 6-8 weeks later. In July. They said in this document, it said that I was too mentally ill to act as next of kin or be informed about my mum's medical care. And they'd also put a DNR notice on the file, which stands for Do Not Resuscitate, which I was really disappointed by because, obviously as her son, my mum has only got 2 sons. She didn't have a husband at the time. She had a boyfriend. And, that there was a very kind of a stark disconnect between the way I felt and what it said in those notes. I didn't certainly want my mum to be denied resuscitation, and I wanted to be involved in her care. She had adenocarcinoma or adenocarcinoma. I can't remember how to pronounce the word. And it's vicious, and it acts very quickly, and it metastasizes all over your body as it did in hers. They actually told me porcupine. They said that she'd lost her last will and testament, and that she had, that she couldn't make a will because she'd lost mental capacity. But she wasn't allowed to get married to her boyfriend. They got something called a registrar's general license, which normally takes ages, but because of the circumstances and the good grace of the local authority, they managed to sort of rubber stamp and push through this registrar's general license. For some reason, like when I was looking at it, they were like saying that they said that she wasn't part of a previous marriage, and on her marriage certificate was a different address, and her death certificate had a different address to the address where she lived, which was with me and my brother at 12 Market Close in Buckfastleigh. Anyway, about 2 years later, I wrote to and phoned up the office of the public guardian and said, could you give me details of my mum's mental capacity assessment? And they said, yeah, certainly. Sent me a letter and said she was never assessed under the Mental Capacity Act. So she could have made a last will and testament. And there's like a Tell Us Once service, right, which is a service offered again by the British, domestic government, and the infrastructure we've got, whereby grieving people can just go to one organisation and make one informed kind of action, and they'll tell everybody. They contact all the banks, all the insurance companies, everything. Cause it's really distressing when you're going through bereavement to have to keep on phoning. There's so much management involved in managing somebody's estate after they pass away. The person who did that actually made a really bad error, which it took me quite a lot of digging and searching through her old sort of papers and stuff to be able to rectify. They thought she owed about, sort of, I can't even remember now. I think it was about $8,000 to Lloyd's Bank, but it turned out she didn't owe them anything at all. But the person managing the estate, they didn't use the Tell Us Once service. I sent my mum's bank statements, death certificate, and marriage certificate about 10 times to about 5 different banks. Sometimes it was faxed from in branch. These were for missold PPI, which eventually we used to pay for a gravestone because there wasn't enough money in her estate to do that. But I found these hire purchase agreement, wet contracts, signed contracts in amongst her archive of sort of stuff in the loft. And yeah, it was just ridiculous. Like HSBC said they lost it, paid me money. Lloyd's lost it twice, paid me money for it. Santander, I think, lost it 4 times. Halifax lost it once. And NatWest lost it as well. So it's 5 banks. And yeah, Santander was faxed twice from in branch. Then I sent it by, every other time was by recorded delivery courier for like 20 quid or 15 quid, with copies of my mum's naturalisation certificate, her marriage certificate and her death certificate, to make sure that all the accounts that she had and a trusteeship which she was a part of. And yeah, they paid me out. I got about $2,500 in compensation. I brought my brother a Hyundai Coupe just because I'd just got given 500 or 600 quid, the money thereabouts by Lloyd's, the first time they lost this package or claimed that they'd lost it. And it kind of felt like, my mum was too ill to make a will, and then they kind of miscalculated the estate. That was supposed to be our statement for account. So what me and my brother are, if somebody gets married through something called the law of intestacy in Britain, your estate passes to your husband or wife or whatever. In this case, because my mum was married to her boyfriend of 10 years before she died on the ward. So this registrar's general license is like if you want to get married in a hot air balloon or on the beach in the Bahamas or like whatever, you can get a marriage. But basically the only place you can get married in the UK, weirdly, is in a church or at a registry office. So yeah, this marriage took place on the ward, and it was like she had the capacity to get married, sign her whole estate away, but she didn't have the capacity to consent to making a last will and testament. Anyway, this is a long intro, 10 minutes now. I'm very proud of the NHS, and I was resuscitated myself a couple of years ago by them. Very grateful for that. The staff I spoke with at that point in the BRI were brilliant, actually. They were all really lovely. There wasn't a single member of staff that didn't act with decorum and respect and, a warm smile and a cup of tea from a nurse or from an HCA. It's amazing what that does, and how just the little things, the general attitude of everybody that provided my care at the BRI was really good. NHS Devon Partnership Trust, who've been responsible for my mental health care, not so good at all. AWP also not great, unfortunately. I think there's a bit of a subdivide between like NHS primary care services and hospital care, and what happens to people under mental health care kind of rules. Don't know what the mic on this laptop's like. I've literally just got it. Somebody smashed my other one up on the ward here, which was lovely of them. And then I got like a monitor, which I've just here, and then they like changed the settings on my old laptop so that I couldn't output it to the monitor unless I kind of like knew the keyboard commands to do it, which blind without any way. Fuck the monitor, fuck all of that shit. I just hope you can hear me, is what I'm saying. So I've done a bit of research into the National Health Service. This document here called The National Health Service at a Crossroads, an exhaustive analysis of scale, financial stewardship and litigation realities. So you can't see it like my normal videos, but you're just going to have to listen to my voice, which I'm just saying I hope you can hear all right. So the institutional scale and the mandate for structural reform, I think there's something deeply important needs to change within. I think it's deeply important that we have a change in our NHS, not just mental health trust, but the entire organisation is so valuable, we can't let it go to waste, and that's exactly what's happening at the moment, in my opinion. And hopefully this document will kind of reflect that. So the National Health Service occupies a unique and central position within the social and economic architecture of the United Kingdom, operating as a universal system free at the point of use. It's a vast logistical and clinical apparatus. However, the organisation transitions through the mid-2020s. Official data, as the organisation, transitions through the mid-2020s, official departmental audits, independent statutory reviews, and internal financial accounts consistently reveal a system operating under acute operational stress and severe financial vulnerability. Despite commanding an annual budget that represents one of the largest single commitments of public expenditure in the world, the health service is simultaneously navigating historically high waiting lists, multi-billion pound legal liabilities stemming from clinical negligence, and extensively documented instances of structural waste and financial mismanagement. The publication of the independent investigation into the NHS in 2024, led by Lord Darcy and commissioned by the Secretary of State for Health and Social Care, unequivocally concluded that the health service is in a critical condition, quote, and in serious trouble. This stark diagnosis has catalysed a unified call for immediate and profound reform from Westminster senior NHS execs. Policymakers have articulated that the survival of the institution dictates a reform or die reality, accompanied by a strict political mandate of no more money without reform. High-level strategic directives encapsulated within the forthcoming 10-year health plan now mandate 3 critical structural transitions, moving care delivery from acute hospital settings to the community, shifting infrastructure from analog legacy systems to digital platforms, and also pivoting the clinical philosophy from reactive sickness treatment to proactive prevention. Brilliant idea. This report provides an exhaustive evidence-based assessment of the NHS, relying strictly on factual statistics and official documentation available in the public domain. It examines the sheer macroeconomic footprint of the organisation, the compounding financial burdens imposed by clinical negligence and litigation, evidenced instances of procurement waste and financial mismanagement, the underlying challenges regarding workforce culture and internal fraud, and also the resulting impacts on clinical capacity and public trust. So the macroeconomic footprint, scale, workforce demographics, and budgetary allocations to accurately contextualise the systemic challenges facing the NHS, it's first necessary to quantify the sheer scale of the enterprise. You might not know this, but the NHS is the largest employer in the United Kingdom, and it ranks among the largest global employers by headcount, operating on a scale comparable only to massive international defence ministries such as the US Department of Defence or the People's Liberation Army in China, and some other major multinational conglomerates. But the workforce composition, diversity and reliance on internal labour dictate that the official NHS workforce statistics, recording data up to 2025, indicate a total headcount of 1,543,716 employees. So 1.5 million people work for the NHS. They are employees working strictly within the NHS trusts and other core organisations in England, which represents 0.7 increase, equating to 10,000 additional individuals from December 24. When factoring in all direct employees, including those deployed within primary care networks and central supporting functions, the NHS in England directly employs approximately 1.7 million people, which translates to roughly 1.5 million full-time equivalent staff, FTE. Current projections outlined in the NHS long-term workforce plan estimate that by 2036 or 37, 10 years' time, the demand for staff will rise between 2.3 and 2.4 million, so an extra million people almost. If met, approximately 1 in 7 of all workers in England will be employed by the NHS, compared to the current ratio of 1 in 17. The operational delivery of the NHS relies heavily on professionally qualified clinical staff, who constitute over half, 54.9%, of the full-time employed hospital and communities health services HCHS workforce. In December 2025, there were 756,442 full-time employed clinical staff, including doctors, qualified nurses, health visitors, midwives, and scientific/therapeutic staff, marking a 2.7 increase, so from the prior year. Within this cohort, the nursing workforce has been substantial, sustained growth. As of November 2025, there were 367,000 full-time employed nurses in England hospitals and community health services, representing a 22% increase over a 5-year period from November 2020, when there were about 300,000, and a 33% increase over a 10-year period, when 10 years ago there was 275,000. So we've gone from 275k up to 367. The demographic composition of this massive workforce is highly diverse and heavily reliant on international recruitment. So lots of people from overseas. Official data from mid-2025 demonstrates that approximately 21% of staff in England report a nationality other than British. Specifically, around 325,000 out of the 1.5 million staff members reported a non-British nationality, representing an increase from roughly 305,000 a year earlier. This international cohort encompasses over 200 different nationalities, notably including 122,000 Asian people, about 8.6%, 70,000 European nationals, about 5%. Furthermore, internal demographic reporting for NHS England indicates that 23.5% of the staff identify as being from a BME background. 10% have declared disability or a long-term condition. Interesting. Budgetary framework. So financial flow and sector deficits. The financial resources required to sustain this workforce and the accompanying clinical infrastructure are commensurate with its size. So employee remuneration accounts for nearly half of the entire NHS operating budget. In 23-24 financial year, the total cost of employing staff within the NHS was 81 billion quid, representing about 50% of the total NHS budget. I don't know if that's budget is the same as turnover. I sort of assumed figures I read made it much larger than that, closer to 300 billion. But this figure notably excludes the salaries of general practitioners who are generally independent contractors, indirectly funded through complex contract systems rather than direct NHS employment. I guess that's the HR budget, it must be. Overall spending for the NHS has experienced significant volatility over the past decade, heavily influenced by the fiscal demands of COVID-19 and subsequent inflationary pressures. In the 2019-20 financial year, pre-pandemic spending was recorded at 157 billion. This expenditure surged to 185 by 22-23 to manage the acute phases of the pandemic and the initial recovery efforts. For 24-25 period, the NHS allocated 151 billion quid of funding to local NHS systems to deliver care and set regional priorities. Projections from His Majesty's Treasury indicate that the overall budget will stabilise at approximately 178 billion annually over the immediate term, though the recent spending review announcement confirmed the government's commitment to injecting an additional 29 billion in annual funding by 28-29 to support a systemic reform, which I think is basically what I'm making this video for. Is I think it's exactly what we need is a reform, and it has to come from within. Specific central allocations within this budget highlight the financial priorities and acute pressure points of the system. For 24-25, the Elective Recovery Fund, ERF, totaled 6.2 billion, aimed directly at mitigating the backlog of 7.6 million people waiting for treatment. Additionally, 5.7 billion quid was allocated to cover higher than anticipated costs for pay awards across multiple staff groups, and 184 million were specifically provided to offset the costs arising from prolonged industrial action by medical staff. Despite these massive capital allocations, the financial architecture of the provider sector remains fundamentally strained. For the year ending 31st of March 2025, the 210 NHS providers generated a total operating revenues of 140.9 billion quid, representing a real terms increase of 5% when adjusted for inflation. So at the close of that period, NHS providers held cash and cash equivalents of 10 billion quid, equivalently only 4 weeks of operating costs in a sector within an annual expenditure of 129 billion quid. Interim financial reports for the 24-25 year revealed a 1.6 billion gap between provider incomes and expenditure by the end of 2024, while the underlying gap between stable incomes and outgoings across the provider sector was estimated at about 4.5 billion in the preceding year. The demand placed upon NHS by policymakers to deliver a 4% increase in productivity, a rate more than 4 times the annual productivity growth achieved in the decade prior to the pandemic, highlights the intense friction between restricted budgetary envelopes and rising operational demands. So, escalating the burden of litigation, clinical negligence, and soaring settlement costs. While the core operational budget is visibly strained by direct clinical delivery and workforce remuneration, a less visible but increasingly disproportionate threat to the NHS financial stability is the escalating cost of clinical negligence claims. The financial liabilities resulting from historical and current medical errors represent a massive compounding drain on public resources, systematically diverting the capital away from frontline care and infrastructural modernisation. To the financial scale of NHS liabilities, according to official audits published by the National Audit Office, NAO, that is, the total sum of money the health service in England may eventually have to pay to settle lawsuits for medical negligence has reached an astounding £60 billion. The Public Accounts Committee, PAC, noted that this figure is astounding and represents the second largest liability across the entirety of the UK government, superseded only by public sector pensions. This represents a quadrupling of total liabilities. This represents a quadrupling of total liabilities from 14.4 billion in 2006-2007, driven by a combination of higher claim volumes, increased survival rates for severely harmed infants, and rising legal costs. The year-end provision, a technical accounting metric, calculating the amount required to settle all the liabilities from instance up to the balance sheet date, was recorded at 69 2.614 billion by NHS resolution for the 23-24 financial period. So the annual cash expenditures required to service these claims are equally severe and continue to follow an upward trajectory. In 23-24, NHS resolution paid out a total of 2.871 billion across all indemnity schemes. The vast majority of this 2.821 billion was specifically allocated to clinical negligence payments. This expenditure breaks down into a 2.106 billion in direct damages to claimants. That was about 75%. And another 545 million in claimant legal costs. So they have to pay for legal litigation as well, which is 19%. Then another 169 million in NHS legal costs, which is about 60%. The data reveals that the NHS is paying more than 3 times as much to fund the legal costs of the claimants trying to sue it than it spends on its own legal defence. This expenditure trajectory continued into 24-25 financial year with 3.09 billion paid against all NHS clinical schemes, representing 9.5% rise from the previous year's figures. The National Audit Office forecasts that the costs of financial negligence will continue to grow, with annual payments for compensation and legal costs predicted to increase from 3 billion in 24-25 to 4.1 by 29 or 30 in a few years. The estimated annual cost of harm, representing the projected total cost of claims resulting from incidents occurring within a single specific financial year, remains extraordinarily high at 5.1 billion across all schemes. So I know there's a really data heavy, lots of stats to take in here, and I'm hoping that you can actually hear what I'm saying. So I'm using my laptop to record this, but the disproportionate impact of maternity and obstetrics claims. So a granular analysis of the litigation data reveals that the financial burden isn't distributed evenly across medical specialities. The volume of claims does not correlate with the financial value of the payouts. For instance, in 24-25, emergency medicine and orthopaedic surgery accounted for the largest percentage of clinical negligence claims by volume, so 13 and 11.5 respectively, while GP services accounted for the largest absolute number of settled cases at 2,914 claims. However, these high volume specialities result in relatively moderate individual payouts. Conversely, claims related to obstetrics and maternity care fundamentally drive the systematic financial liability in the NHS. In 23-24, obstetric claims accounted for only 12.8% of clinical claims by volume, but represented a staggering 56% of the total value of clinical claims received. The highest value claims are consistently those associated with severe brain injuries, such as cerebral palsy, suffered by infants during childbirth. The NAO revealed that maternity claims cost an average of £112 million each to settle. £11.2 million each to settle. In 24-25, costs specifically associated with brain injuries in maternity care reached £1.5 billion, and by comparison, the next most expensive categories were just entitled Other, 337 million, and General Paediatrics about 325 million. These astronomical individual figures are legally mandated because harmed infants require continuous, complex and highly specialised care for decades. Damages are calculated to include compensation for pain and suffering, lifelong care costs, educational support, profound accommodation adaptations and future lost earnings. The clinical realities behind these figures have been subject to intense, highly critical public scrutiny, most notably through the independent Ockenden review. So that review investigated maternity failings at the Shrewsbury and Telford Hospital NHS Trusts, undertaking 5-year investigations that examined cases spanning from the millennium 2000 to 2019, so about 20 years. That final report concluded that more than 200 babies may have died due to repeated systemic failures, highlighting a clinical culture that failed to investigate, failed to learn and failed to improve, and often failed to safeguard mothers and babies at their most vulnerable. The review noted a profound lack of transparency and honesty at the Trust, with staff describing being frightened to speak to the review team about clinical errors. The resultant financial claims from such protracted systemic breakdowns directly fuel the multi-billion-pound provisions held by NHS resolutions. So dispute resolutions, legal trends, and out-of-court statements is the next chapter in this document I'm reading. It says, in response to the spiralling costs of legal fees and the emotional toll adversarial litigation takes on patients and staff, NHS Resolution has aggressively pursued alternative dispute resolution mechanisms. So the explicit strategic objective is to keep patients and their families and the healthcare staff out of formal court proceedings whenever possible, focusing on mediation, resolution meetings, and stock take discussions. This strategy has yielded notable statistical success in recent years. In 23-24, a record of 81% of clinical claims were resolved without formal court proceedings. This metric improved further in 24-25, with 83% of the 14,000 new medical negligence claims settled without litigation, allowing over 11,100 claims to be resolved through negotiation and non-adversarial processes. Don't know how I feel about that, really. I mean, I guess it's necessary. How do you resolve it? I mean, non-adversarial claims. I mean, how does that even adversarial processes like out of court settlements are better than litigation? I guess one must assume. Generally, it reads, only the most severe, complex, and highly contested cases reach the courtroom. In 23-24, only 50 clinical and non-clinical resolved claims were litigated to a trial. Of these, the court awarded damages in only 17 cases, so 34% that is, and 33 cases resulted in no damages being awarded, as the court agreed with NHS Resolution's assessments of the merits. Crucially, of all the claims that were resolved both in and out of court in 23-24, 52% resulted in the payment of damages, indicating that more than half of all claimants received compensation. Excuse me, a little burp there. In 24-25, this figure rose to 54%, with 7,806 clinical claims closed with compensation. Despite these operational deficiencies in the legal and settlement process, the underlying cost of severe clinical harm continues to push the total payout figures higher year on year. The average amount of compensation in 23-24 was £204,000, quite a bit across all claim types, a figure heavily skewed by the multi-million-pound maternity settlements. This unsustainable trajectory prompted the National Audit Office and the Department of Health and Social Care to explicitly warn the government could be paying twice in some cases, setting a claim and then funding further NHS treatment for the same claimant, and to demand that ministers consider new legislative approaches to compensating for negligent treatment. So the financial mismanagement, structural waste and procurement failures in the NHS is what the next chapter is about. It reads, the unified call for structural reform from Westminster is not solely predicated on the unavoidable costs of direct clinical care and litigation. It is heavily driven by a documented historical pattern of financial mismanagement, inefficient procurement practices, and structural waste. Official reports from the National Audit Office and the PAC, don't know who that is, but they and other independent think tanks present a recurring theme of capital misallocation that severely undermines the financial sustainability of the NHS and basically compromises its ability to deliver value for money to the taxpayer. One of the problems is the contingent labour market. So you've got a lot of agency staff and then bank staff operating within a similar dynamic. So one of the most persistent and viable areas of financial leakage within the NHS has been the management of contingent labour. Over the past decade, hospitals have increasingly relied on temporary agency staff to fill chronic roster gaps, cover sickness absences and maintain safe ward ratios. However, staff supplied by external private agencies cost the NHS on average 20% more than internal NHS bank staff. So they're just hemorrhaging cash in that instance. The absolute financial drain of this reliance has been substantial. In 2022-23, NHS providers spent £3.46 billion on agency staff, loads of money, a small amount of the budget, but still a lot of money. And they're 20% more expensive than NHS staff. They get paid more, they cost more to hire. Following widespread concern over the exorbitant rates charged by private agencies, the Department of Health and Social Care introduced strict agency spending limits, ordering trusts to reduce their agency spend by 30%. This directive appeared successful on the surface. Agency spend decreased to 3.02 billion in 23-24 financial year and further reduced to 2 billion in 24-25. This reduction of nearly 1.4 billion over 2 years was publicly heralded as an almost £1 billion boost for the front line, which is brilliant, really. However, deeper statistical analysis reveals a complex displacement effect. So the cuts in external agency spend have been directly offset by escalating uncontrolled expenditures on internal NHS staff banks. So data shows that medical and dental bank spending increased dramatically from 902 million in 29-20 to 1.4 billion in 22-23 and up to 1.9 billion in 23-24, which is a 114% increase since 2019. Consequently, rather than saving money, total expenditure on medical temporary staffing actually increased by 18%. So that's 470 million between 22-23 and 22-24. This dynamic illustrates a whack-a-mole scenario in workforce financial management, where price caps and controls on external agencies fail to address the underlying structural reliance on temporary labour, merely shifting the premium costs onto internal staffing banks. So then the next bit is about pandemic procurement and failures, the £9.9 billion write-off. So the systemic vulnerabilities of NHS and DHSC procurement processes were glaringly exposed during the COVID-19 pandemic. In the urgent rush to secure personal protective equipment, PPE, within a highly competitive and disrupted global market, normal competitive procurement rules were suspended by the Cabinet Office in March 2020. The National Audit Office reported that by July 2020, 10 billion quid of the 18 billion total pandemic procurement spending was awarded directly without any competition. So just £200 million was awarded using a competitive tender process or competitive bidding. So they just found a buyer and just took the first option. They didn't kind of like let a laissez-faire or cheapest possible budget take place, giving people a chance to kind of bid on it. They just awarded it, and you've probably seen that in the papers and stuff. This suspension of standard due diligence resulted in a catastrophic financial write-offs. So a net of 19 million quid's worth of PPE was just written off in 23-24 alone. However, this is dwarfed by the fact that most of the write-offs are recognised in prior years, totalling a staggering 9.9 billion. The Controller and Auditor General, that's C&AG, subsequently qualified their opinion on the Department of Health and Social Care 23-24 accounts. The qualification was issued because the 23-24 accounts contained the 22-23 figures, which lacked sufficient evidence to support in-year transactions and prior year comparatives relating to COVID vaccine unit and the massive PPE losses. An investigation revealed significant transparency issues too, with billions flowing through government-established high priority lanes, it quotes, favouring companies referred by senior officials, ministers and parliamentarians themselves. Many of these contracts were awarded to suppliers lacking clear assets or prior experience in healthcare logistics. For example, the NAO noted that Supply Chain Coordination Limited had ordered PPE worth £1.717 billion from one single supplier, Full Support Healthcare, an order that was subsequently heavily scrutinised by the PAC. Then you've got legacy IT failures, so the National Programming for IT. Historical capital management figures continue to cast a long shadow over the NHS's contemporary digital transformation aspirations. The most egregious historical example is the National Programme for IT. Launched in 2002, the ambitious initiative claimed to ensure that every NHS patient had a universal electronic health record that could be shared seamlessly across the system. Originally budgeted at 2.3 billion quid over 3 years, the project suffered from severe scope creep, an absence of phased change management and a lack of end user engagement, and intense resistance to top-down implementation, from total clinical organisations. The programme was officially dismantled in September 2011 after costs spiralled uncontrollably. Estimates placed the financial projected cost at 12 billion quid over 11 years, with the NHS having spent over £7.6 billion by the time it cancelled. The PHC condemned the initiative as one of the worst and most expensive contracting fiascos in public sector history, ultimately costing the taxpayer an estimated 10 billion quid in wasted capital. Furthermore, contract management was heavily criticised. When a major IT provider, Accenture, withdrew from the project in 2006, the Director General for the NPFIT charged them only a £63 million penalty rather than the billion quid that the contract permitted. This historical mismanagement remains highly relevant as Lord Darcy's 2024 report mandates a reviewed systemic transition from analogue to digital, an objective met with deep institutional scepticism given the legacy of the NPFIT and subsequent IT contracting failures involving major firms. The crippling burden of private financial initiatives, PFI. So another massive structural financial constraint is the legacy of private finance initiatives and public-private partnership contracts, utilising heavily in previous decades to fund the construction of new hospitals without immediately increasing the public borrowing figures on the national balance sheet. The PFI contracts bound the NHS to infixable decades-long repayment schedules to private consortia. The long-term financial consequences are severe and ongoing. Across the public sector, reliance on PFI, that's a public financial initiative, combined with governments cutting capital expenditure during economic downturns, has resulted in a staggering 37 billion quid backlog in maintenance. There's a lot of stats in this. I hope you're able to factor them in without being able to read like you normally can. Of which 10 billion quid sits directly within the NHS. So that's the backlog in maintenance. In Scotland alone, the Public Spending Watchdog Audit Scotland reported that the NHS would have spent 10 billion quid by 2045 to pay for roughly 50 contracts to actually build facilities, initially worth only 2.2 billion. So 4.8 billion is being paid out between back in 1998 and 99 up to the 23-24 year, with 5.8 billion still owed between 24 and 25-46. In England, that probably sounded really confusing, but in England, the net finance cost for the NHS in 24-25 alone stood at 1,933 million. Or 1 billion, 1.9 billion, I think I should say. Significant portion of which is tied to remeasurement on PFI, similar scheme liabilities. These high-cost contracts continuously drain operational budgets, limiting the capital available for modern clinical delivery and escalating toxic disputes between NHS trusts and private facilities management firms over defect deduction. So the effective, it's just, again, hemorrhaging money. Executive accountability and golden goodbyes. Compounding public and parliamentary concern over financial stewardship is the issue of executive accountability, specifically regarding unapproved or highly generous severance payments made to departing senior executives, often termed golden goodbyes. In the 23-24 financial year, 5 such unapproved patients totaling 180 grand unapproved payments totaling 180 grand were made by NHS trusts. So the National Audit Office explicitly noted that, on quote, without approval, this expenditure has not been spent in line with Parliament's expectations. So giving 5 people got 180 grand just because they were leaving their role on top of their salary that they'd earned at the job to say goodbye. Furthermore, NHS England acknowledged that it lacks the ability to identify any meaningful consequences or enforce deterrence against trusts that violate these rules, relying solely on reminding providers of the regulations. In an attempt to standardise oversight, NHS England and the Department of Health and Social Care published an updated very senior manager VSM pay framework in May 2025, which focused on performance-related pay linked to the NHS performance assessment framework through historical precedents. Though historical precedents suggest enforcement remains challenging. Sorry if I can't get my words out. I'm on quite a lot of medication at the moment. Then you've got fraud, bribery, and systemic corruption risks. This isn't libelous or defamatory, but it reads, beyond structural waste and legally binding PFI contracts, the NHS faces targeted malicious financial threats through fraud, bribery, and corruption. The vast annual budget and highly complex supply chains present lucrative opportunities for the illicit extraction of public funds by both internal staff and external contractors. The statistical picture of NHS fraud. So the NHS Counter Fraud Authority, established to combat these specific threats, reported receiving 6,400 reports of suspected fraud in 24-25 financial year. The vast majority of these reports, over 80%, related to 4 core thematic areas. You had NHS staff fraud, patient exemption fraud, procurement and commissioning fraud, and then the fourth one is fraudulent access to NHS care from overseas visitors. In total, the NHS Counter Fraud Authority's strategic oversight estimates about 1.2 billion quid is lost annually to fraud, error and loss, whatever loss is, across the health service. Procurement and commissioning represent the most financially devastating factors for fraud. Counter Fraud Authority assesses about 392 million quid is financially vulnerable to fraud out of an annual procurement budget of 35 billion. So like 10%. But yeah, the threat landscape in this sector is highly complex, involving pre-tender bribery, collusive tendering, contract splitting, single tender waivers and falsified invoicing. The National Fraud Office assesses it's almost certain that some decision makers are susceptible to bribery from suppliers utilising techniques like private residency building work or accepting hospitality to disguise their behaviour. There is also concern that the new provider selection regime, PSR, might enable those in decision-making positions to avoid competitive tendering, again getting the cheapest person to do it, by arguing that a change of supplier is not required. Within internal operations, staff fraud is rampant. Of the 32,211 reports specifically concerning staff in 24-25, 62.6% related to false income and hours, for example, inflating income by falsely claiming hours not worked or working somewhere else during NHS contracted hours. 16% related to suspicious insider activity, whatever that means. To combat this, the NHS Counter Fraud Authority targets financial recoveries and prevention. So in the year 24-25, they achieved almost £296 million in savings, working towards a strategic target of 500 million quid. High profile prosecutions and executive malfeasance. So the abstract statistics of systemic fraud are grounded in several high profile criminal convictions. These, it reads, highlight the severe vulnerability of the organisation's management and procurement layers. In a landmark case known as Operation Bukowski, 4 men were convicted of bribery and corrupt practices regarding an award of £6 million in telecommunications and video conferencing contracts for NHS Scotland. The investigation revealed that between 2010 and 2017, 2 senior NHS IT executives accepted bribes, hospitality and cash incentives worth about 100 grand in exchange for providing sensitive tender information to the directors of a private firm. Many of these incentives were later paid for by the NHS through false, inflated or duplicated invoices. The subsequent trial in 2025 resulted in a combined 29 years imprisonment for the 4 perpetrators who did that horrible shit, underscoring the egregious abuse of position by public officials. Similarly, the case of Paul Vasco Knight further illustrates executive malfeasance at the highest levels. As the former national lead for equality of the NHS England and CEO of an NHS Foundation Trust, she and her husband were convicted of defrauding the NHS of 11,000 quid. Vasco Knight authorised payments to her husband's graphic design business for a leadership document that never existed. When placed under investigation by NHS to protect, the couple attempted to retrospectively manufacture the document to justify the invoice, plagiarising large passages of text from a King's Fund publication. They subsequently pleaded guilty to fraud, received suspended prison sentences and unpaid work requirements. Somebody scamming 11,000 quid is like really very much a minor detail in terms of what goes on. Things I've read about. There's a table here. It's got the counter fraud vulnerability metrics. Total suspected fraud reports were 6,000. Estimated annual fraud and error loss 1.2 billion. Vulnerable procurement spend was 392 million. Annual recovery prevention targets was 196 million. Primary staff typology with false income and hours accounted for 62.6%. Fraudulent access by overseas visitors, 43.5 million estimated loss. Workforce culture, harassment, attrition and whistleblowing metrics. The profound structural and financial challenges facing the NHS are inextricably linked to welfare, morale and psychological safety of its £1.5 million strong workforce, 1.5 million people strong workforce. The ability of the organisation to retain staff, improve productivity and ensure clinical safety is deeply compromised by a corrosive internal culture documented across multiple official surveys and independent investigations. The crisis of physical and sexual safety. This is a bit shocking. So it says that frontline NHS staff operate in an environment increasingly characterised by physical danger and harassment. The 2024 NHS staff survey, one of the world's largest workforce surveys, over 766,000 respondents, revealed alarming levels of violence. Almost 1 in 7 NHS staff members, about 14%, reported literally being physically attacked by a patient or the public in the preceding year. That's the highest rate in 3 years. Furthermore, nearly 10% of staff stated they experienced discrimination from patients or the public, highest level since records began. A particularly disturbing subset of workforce data relates to sexual safety. A joint investigation by the British Medical Journal and The Guardian revealed that more than 35,000 sexual safety incidents were reported to 212 NHS trusts in England in 2017 and 2022. I don't really understand how it says. That means 212 reports, I think, including cases of rape, sexual assault and stalking. Of these incidents, 62% staff members. When the NHS staff survey explicitly measured this for the first time in 2024, the results were pretty stark. So almost 9% of staff reported that at least one incident of unwanted sexual behaviour from patients or the public in the past year, and 3.5% reported incidents involving colleagues. So that's other NHS staff, 3.66%. Out of 1.5 million staff, that's a lot of people getting abused by their own colleagues sexually within the NHS. That might sound like a nominal figure. Sorry, my fucking keyboard's camera's wobbling. But if you just sort of take that, try and imagine that 3.66% of insults involving other colleagues. There's only 50 NHS trusts or something like that. There's only so many hospitals. This hazard is exceptionally acute for ambulance staff, where almost 1 in 3, 31%, reported being subjected to unwanted sexual behaviour. In response, NHS England expanded its domestic abuse and sexual violence programme to embed a zero-tolerance approach, yet the normalisation of misogynistic behaviour and harassment risks severe reputational damage and staff attrition too. Then you've got internal bullying and the legacy of somewhere called Mid Staffordshire. So internal bullying from management and colleagues remains similarly pervasive. The 2024 survey indicates that 17.6% of NHS staff experienced bullying or harassment in the last year, with 9.5% citing direct bullying from their own managers. These statistics disproportionately affect ethnic minority groups at 28%, disabled staff at 23%, and LGBTQ plus staff as well. The British Medical Association has described this environment as a corrosive culture, estimating that toxic behaviour, subsequent staff absences and related mental health impacts cost the NHS upwards of £2 billion every year. This cultural toxicity has direct implications for clinical safety. The Francis inquiry, published in 2013 into the Mid Staffordshire NHS Foundation Trust, laid bare the fatal consequences of a culture of bullying and intimidation that hobbled the nursing voice, leading to a failure to raise alarms over egregious failures in care and caused hundreds of unnecessary deaths. Just Google it, have a look at the Mid Staffordshire NHS Trust. In fact, I've made a video about it before, I think. Despite the introduction of 290 recommendations, including a statutory duty of candour and the establishment of freedom to speak up guardians, experts like Sir Robert Francis have recently warned that current pressures mean what we are witnessing across the NHS, it quotes, is the Mid Staffordshire scandal playing out on a national level. Then you've got whistleblowing and non-disclosure agreements. So the protection of staff who identify clinical and financial failings is a critical component of institutional integrity. In 23-24, NHS England received 433. Sorry, just had to pause there. They're doing my observations again. So NHS England in 23-24 received 433 formal whistleblowing disclosures, of which 257, that's 59%, were deemed in scope regarding criminal offences, health and safety endangers or cover-ups. While the Employment Rights Act 1996 does protect whistleblowers in theory from victimisation, high-profile employment tribunals continue to highlight the emotional and professional toll on staff who do to try and speak out. Cases such as Jury versus South Central Ambulance Service NHS Foundation Trust emphasise the psychological harm and injury to feelings that arise from workplace retaliation against whistleblowers. Compounding this issue is the historical use of settlement agreements containing non-disclosure agreements, which basically means they'll give you a load of money if you shut the fuck up and don't tell anybody. As it goes on to describe them here as gagging clauses. These legal instruments have routinely been used to quietly remove whistleblowers or underperforming executives from the organisation, practice that the government has pledged to reform but which continues to obscure systemic failures and suppress transparency. System performance, avoidable mortality and the collapse of public trust. So the ultimate consequence of financial strain, administrative waste, litigation costs and workforce demoralisation is a severe degradation in clinical output and patient outcomes. The operational data indicates a system struggling to meet basic demand. Capacity constraints and avoidable mortality. So physical capacity within the NHS is severely stretched. In the final quarter of 24-25, January to March 2025, out of the 106,000 available general and acute beds, 98,000 were occupied. This equates to a bed occupancy rate of 92%. Since 2010, average bed occupancy has continually surpassed 85%, which is the threshold generally considered by medical bodies such as the British Medical Association to be the maximum limit for safe and efficient operation. Occupancy rates exceeding 90% inevitably lead to severe bottlenecks in emergency departments, delayed patient transfers from intensive care units, and a stagnation of overall hospital productivity. The most profound and definitive metric of system failure is avoidable mortality, deaths that could have been prevented through proactive public health interventions or treated through timely, effective healthcare. In 2024, the ONS reported 21% of all deaths in England and Wales, that's 113,000 people, were considered preventable or treatable. 21% of all deaths in England considered preventable or treatable. This resulted in an age standardised mortality rate, ASMR, of 227.6 deaths per 100,000 people. In Wales, the figure stood at 22%, 8,000 deaths, and in Scotland it reached 26%, which is 16,000 deaths with an ASMR of 307.1 per 1,000. So out of every 100,000 people who died, 307 died in a way that could have been prevented or avoided if somebody did their job better. Really tragic. The data reveals stark geographical and socio-economic inequalities. In England, the highest rate of avoidable mortality in 2024 was in the northeast. That's 280 deaths per 100,000 compared to the lower rate in the southeast, 193. Across the UK, the most deprived areas experienced avoidable mortality rates nearly 4 times higher than the least deprived areas. Then you've got the collapse of public satisfaction. So the culmination of access failures, clinical delays, and a persistent 7.6 million person waiting list has fundamentally eroded the public's perception of this institution. The British Social Attitudes Survey, a highly respected and long-standing barometer of public sentiment, recorded a historic collapse in NHS satisfaction. In 2024, only 21% of British adults reported being very or quite satisfied with the way the NHS runs. This represented a steep 39 percentage point decline since 2019 and the lowest level of satisfaction ever recorded since the survey began in 1983. Conversely, dissatisfaction rose to a peak of 59% in 2024. Satisfaction with GP services similarly plummeted to a record low of 31%, whilst the 2025 BSA survey saw a slight statistical recovery, with satisfaction rising 6 percentage points to 2026 and dissatisfaction rate falling to 51%. The underlying metrics regarding waiting times and access to core services remain severely suppressed. Interestingly, the public belief in the foundational ideological principles of the NHS remains absolutely resolute. In 2025, 89% of respondents agreed the service should be free of charge. 81% agreed it should be primarily funded through taxation, and 74% agreed it should be available to everyone. This dichotomy indicates that public anger is not directed at the model of nationalised health service itself, but squarely at its contemporary operational delivery, management, and lack of systemic efficiency. In conclusion, the Westminster mandate for structural overhaul. The factual statistics aggregated from official audits, departmental accounts, independent inquiries and national surveys paint an objective, undeniable picture of an organisation at a critical juncture. The National Health Service is managing a colossal core budget exceeding 150 billion, supported by a workforce of 1.5 million full-time employed staff, yet it's deeply encumbered by £60 billion in clinical negligence liabilities, drained by multi-billion pound legacy debts from private finance initiative contracts and historic IT failures, and remains consistently vulnerable to procurement waste and internal fraud. This empirical reality forms the basis of urgent calls for reform emerging from Westminster and senior NHS executives. The Darcy Review explicitly outlines that pumping capital into the current structural framework without fundamental operational shifts is financially untenable. As noted by the Secretary of State for Health and Social Care, the system faces 3 mandatory shifts. So there's from analogue to digital, from hospital to community, and from sickness to prevention. Ultimately, the data dictates that ensuring the survival of the NHS requires far more than passive fiscal injections. It demands rigorous financial stewardship to eliminate the billions lost to uncompetitive procurement and fraud, aggressive clinical safety reforms to halt the astronomical rise in maternity negligence claims, and a concerted policy-driven effort to dismantle the toxic workplace cultures that drive staff attrition and endanger patients. The mandate for reform is no longer ideological or theoretical. It's an immediate financial and operational imperative dictated by the data. Thanks for watching. Sorry about the noise. I'm on a psych ward in Western-super-Mare.